next Monday, so driving all my stuff down over the weekend. So I've been here 9 months. It's been quite a wonderful experience thus far. I've got to work and meet a lot of you, work with a lot of you and meet you all, many NAMI participants, and I've really enjoyed that, having interplay. And we're doing a lot of great things at DMH. To let you know, my primary responsibility at this point, this early on, is to recruit, to get enough psychiatrists into our clinics so that we can support our patient population and not just give satisfactory care, but exceptional care. That's really our goal. And our goal is to be able to provide exactly the same level of care, if not better, and I think we can do better than any private insurance agency that exists today. So this is our goal, and in order to do that, we need to fill up our psychiatry spots, and we have a lot open. But we're doing some things that really are quite novel, including moving forward what I did with the VA, which is a massive telehealth initiative, so that our physicians can call in from anywhere and staff our clinics and actually be part of multidisciplinary teams. I have no doubt, if any of you saw Dr. Partita's presentation, that he talked about the multidisciplinary team and the multidisciplinary approach. He, and all of our colleagues are very invested in the multidisciplinary approach. We believe it, we live it, we breathe it, and this is what we're bringing into DMH. Not just everybody sign the same treatment plan and work in their own offices, but that really work together in a robust way. And as Dr. Partita might have told you as well, our goal is to actually bring the patients into the treatment team setting as members of the treatment team. That's the only way that we can support recovery and respect the patients like we respect ourselves. So this is the lofty goal, but we will get there because all of my colleagues think in exactly the same way as I do. And this is what we plan. It's absolutely imperative that the patient, the client, be part of the treatment team and participate in the decision-making process, not just to control his or her own care, which is extremely important, but to see the deliberations of the different staff members and actually be able to have interplay with the different staff members. It's imperative that they know what's going on and we know what's going on with the patients.
That's right.
So that's our goal. Now, I know I've been droning on. I know that medication is part of the title of this breakout session, and let me tell you what we're doing with medications here. I have just hired a new chief pharmacist for the Department of Mental Health. I had a team, a selection team that really looked very carefully at all of our candidates for the chief pharmacist, and I actually didn't take their selection. I chose my own, because their selection was someone who had worked in DMH for many a year before, and I didn't want that. I wanted someone to come in with new ideas, new blood, a youthfulness that can help really push forward changes and not accept what the status quo is at DMH. DMH, you always hear, oh, the system is holding us back. The system isn't holding us back. It's our own minds that are holding us back, and we really need to push forward with all these initiatives. Fortunately, the chief pharmacist I've chosen has been very helpful to me in doing that. We have now, for the first time ever, long-acting injectable medications that are actually on our formulary, and it's time for us to really move into the 21st century of treatment. We have medications that treat substance use disorders and cravings that are on our formulary. And right now, because of the laws in California, we're not really allowed to bill for substance use disorder treatment, but that don't matter. As Dr. Sharon has always said, just do the right thing. Don't worry about the cost. We got money, we'll pay for it, and that's what we're trying to do. So we have these medications on our formulary, and we're going to instill a treatment program that is second to none It's going to take a while because all of our doctors are kind of stuck in the old ways, but we're going to move them forward, and we're going to institute a real, robust substance use disorder treatment with medications, with psychotherapy, with counseling, with groups in DMH, and we're going to do it and still be more efficient than we were before. So within the next year or so, that's going to come about, and we have very, very big agencies working with us on this. I have recruited members of our UCLA partners who are substance abuse experts, ISAP, and they are going to help us look at our resources that we have now and institute new resources and help us really develop a treatment plan that works for all the clinics that we can really implement as soon as possible and robustly. Substance use treatment, in our opinion, should not be separated in any way, shape, or form from mental health treatment. We don't separate human beings into pieces of a pie and move them to different areas. Our goal is to keep the human being whole, because that's how we live and breathe. We're individuals, we're not disorders that we lump into different areas. So we're going to integrate substance use disorder treatment into our regular mental health treatment. From our perspective, they are one and the same, and we can't treat one aspect of a patient's illness unless we treat all of them together in an individual way that supports the patient's needs, desires, and goals for the future. Our goal is not just the word recovery is thrown out all the time, including at DMH, but we're really now trying to support real recovery, which means we challenge patients. Patients can do whatever they want. We believe that. We believe people can recover from very severe illnesses, and we don't want to treat diagnoses. We treat patients and we treat symptoms. Diagnoses are just stuff that the books say, but they think certain people into categories, but that's not appropriate. What's appropriate is to find out what the patient needs and how do we get that patient to where he or she wants to be. It sounds pretty simple, but that's not how medicine works these days. So what that means is it's kind of like a career counselor. You meet with a patient, you say, what are your goals? Let's come up with a roadmap to get you to where you want to be. And when I say we challenge patients, I don't mean that we're making demands of patients, but sometimes patients themselves have been beaten down over the course of time in the old model, the paternalistic model, that believes that people can't go further. But we've seen evidence that people can go further, and we want to challenge our patients, our clients, in order to shoot for the stars, because actually many of them can get there and live real enriched lives, regardless of whether or not they have mental illness, and regardless of whether or not they've had a substance use disorder in the past. So this is our goal. And I think we can get there. And we have a discipline chief who's our peer discipline chief, who has had lived experience and is now one of the executives with the rest of us in the Office of Discipline Chiefs. She's wonderful, she's bright, articulate, and she is going to help us get to where we need to be. We're bringing in new medications. We're drastically expanding pharmacy resources. Our goal from a psychiatric perspective is to get out there in the streets where people live. And because we know there's a large group a large part of our population that is afraid to come into our clinics. Why are they afraid? They don't like the stigma of mental illness, number one. Maybe they've been treated poorly in the past. Maybe they didn't get what they asked for. And maybe they were scared to death that they would be brought to a hospital as soon as they went to the clinic involuntarily. And that's not something that we want to continue to foster, that kind of an environment. That's very backwards. And they have a right to be fearful, is what I'm saying. because that stuff kind of did happen. And working in psych ERs most of my life, I've seen that happen firsthand. And I'm a big patients' rights person. So we want to get out there in the streets. That means the psychiatrists go out there in the streets along with everybody else. And they work as if they're on a beat. Like in an urban center, people typically are suspicious of police officers, right? And they have a right to be. But when you have a police officer on a beat, you see that person on the street walking back and forth every single day. Eventually, maybe you'll strike up a conversation, talk about the Dodgers, talk about the Lakers. Well, I mean, talk about the Dodgers. Let's forget about the Lakers. They're not doing too hot. But after that, after you establish some degree of trust, then you start talking about issues. Maybe then you give some information about what's happening in your community. The same is true for psychiatrists. A lot of people don't trust psychiatrists. And so we're going to try to make that happen where a psychiatrist has a beat, and over the course of time, they start to be trusted. Some of those people who start to trust their psychiatrists will be able to get to the clinics, some not. That's okay. We'll treat them out there in the street. And how does a psychiatrist treat someone in the street? Psychiatrist typically prescribes medicines. Well, our goal is to be able to provide medications right out there in the community. And I don't just mean giving injections out there in the community. I mean being able to provide bottles of medication as needed right out there, so the patient doesn't have to go to a pharmacy himself or herself, let alone go to a clinic. You know, the same problems that exist for people getting to clinics are the same problems that exist for people to get to pharmacies. Most of it revolves around transportation, and those who are just trying to survive day by day maybe don't have time to come in for a clinic appointment or go to the pharmacy. So we want to respect that and really work with our patients where they live and breathe. And I think we can do that. We have 11 new psychiatry spots open just for street psychiatry, and we're going to fill those spots, and that's what's going to happen. How are we going to bring medications out there in the street? Well, I, with my pharmacy chief, have a plan to develop a courier service that can bring medications either from our headquarters, so in Koreatown, or from actual pharmacies to provide them right to the patients where they live and breathe. And this is so this is, I made this an innovations project. We have money for this, so we're investigating it right now. Oh, Q&A, yeah. I tend to drone on, I apologize. So let's talk about what you guys want to talk about. Let's have a Q&A, and you've heard my spiel, and I'm very happy to answer questions. That's part of the day.
And I'll ask folks to take their question to the edge, unless it will be easier for me to. I think I'm going to ask you to form a line, and if you're here, you can form a line here, and I'll bop between the two sides. Thank you.